Good morning everyone, myself Charu Saraswat, roll number 26, myself presenting topic of anti-anginal drugs. So let's begin with basic physiology and mechanism behind angina and myocardial infarction. Angina pectoris is a symptom of ischemic heart disease. There are three types of angina pectoris, that is stable angina, unstable angina and prismental or variant angina. Let's talk about pathophysiology. Angina occurs due to imbalance in oxygen supply and oxygen demand by the myocardial tissue. There are two reasons for myocardial infarction. It may be decreased oxygen supply or increased oxygen demand, like coronary atherosclerosis, increased heart rate, increased ventricular wall tension, coronary thrombosis, etc. Treatment is aimed at maintaining the balance between oxygen supply and demand. So, we can further use PCI, that is percutaneous intervention, or CABG, that is coronary artery bypass grafts, to restore the coronary blood flow. It increases oxygen supply to the myocardial tissue. We can also increase oxygen supply to the myocardial tissue by using drugs like CCBs and nitrates. CCBs here are calcium channel blockers. We can also further decrease oxygen demand of the myocardial tissue by decreasing preload, mainly by nitrates, decrease afterload by CCBs and potassium channel openers, and we can also decrease heart rate and contractility by using beta-adrenergic blockers. Classification of anti-anginal drugs. The first drugs are nitrates. It includes nitroglycerin, isosorbate dinitrate, isosorbate mononitrate, etc. Second are beta-adrenergic blockers, that is propranolol, metoprolol, atenolol, etc. Then the third class is CCBs or calcium channel blockers. It includes verapamil, diltiazem, nifedipine, amlodipine, etc. Then the fourth class includes potassium channel openers. It includes nicorandil. Then there are other miscellaneous drugs like antiplatelet drugs like low-dose aspirin, clopidogrel, prasugrel, statins, trimetazidine, ranolazine, ivabradine, etc. Now let's begin with organic nitrates. Organic nitrates are products that is they release nitric oxide. Nitrates are mainly venodilators and also cause arteriolar dilation and reduce both preload and afterload on the heart. Now mechanism of action of nitrates. What they do is release of nitric oxide in the smooth muscles and they stimulate guanylyl cyclase. It increases CGMP and it causes dephosphorylation of myosin light chain kinase, that is MLCK, and it decreases calcium concentration in the cytosol and it leads to the relaxation of the vascular smooth muscle fibers. Now pharmacological actions of nitrates. Nitroglycerin is the prototype drug of nitrates and has no direct action on the heart. So now let's talk about the actions of nitrates. The first is on the vascular smooth muscle. Nitroglycerin quickly relieves anginal pain by decreasing the oxygen requirement and increasing oxygen delivery to the myocardium. The other types of smooth muscles of bronchi, esophagus, biliary tract, etc. are relaxed by nitrates. Now pharmacokinetics of nitrates. Organic nitrates are readily absorbed through the buccal mucous membrane, the skin and the GIT. All nitrates except isosorbate mononitrate undergo extensive first-pass metabolism in liver and hence oral bioavailability of nitrates is very less. Sublingual route produces rapid onset within 2 to 5 minutes but short duration of action. Absorption through skin is slow, hence transdermal route is used for a prolonged effect. The metabolites are excreted mainly in urine as glucuronide derivatives. Now let's talk about the adverse effects of nitroglycerin. Adverse effects are due to extensive vasodilation. They are headache, postural, hypotension, tachycardia, palpitation, weakness, flushing and rarely syncope. To avoid these symptoms, the tablet may be spit out as soon as the pain is relieved. Overdosage may cause methyglobinemia. Tolerance to nitrate occurs on prolonged use of nitrates orally as transdermal patch or IV infusion. Development of tolerance is rare following intermittent exposure, that is sublingual GTN. Tolerance is due to decreased NO generation, depletion of sulfhydryl radicals in the cell or generation of free radicals, etc. Nitrates also exhibit cross tolerance. Tolerance can be prevented by giving a nitrate-free interval, that is 8 to 12 hours per day or maybe during sleeping. Besides isosorbate mononitrate, there are also other types of nitrates like isosorbate dinitrate and isosorbate trinitrate. Then let's talk about therapeutic uses of nitrates. The first use is for angina. It also has its two use, like for acute attack of angina and for prophylaxis of angina. For acute attack of angina, nitroglycerin is the drug of choice. For an acute attack, nitroglycerin is commonly administered sublingually with an initial dose of 0.5 mg that usually relieves pain within 2 to 3 minutes. Patient is advised to spit out the tablet as soon as the pain is relieved. The tablet can be repeated after 5 minutes but not more than 3 tablets in 15 minutes. For prophylaxis of angina, longer-acting nitrate preparations are used, like isosorbide mononitrate orally, isosorbide dinitrate orally, and nitroglycerin oral sustained-release preparation, ointment, discs, or patch. Transdermal nitroglycerin produces prolonged effect up to 24 hours. To avoid tolerance, the patch should be removed for a few hours, that is at least 8 hours per day. The variant or the prizmental angina is due to coronary vasospasm. Episodes of coronary vasospasm are treated with nitrates. For prophylaxis, nitrates and calcium channel blockers like amlodipine and nifedipine and diltiazem are effective. Addition of a CCB with nitrate produces better efficacy in variant angina and also reduces the incidence of MI. Then in unstable angina, it requires treatment with multiple drugs, like antiplatelet drugs, including low-dose aspirin, clopidogrel or prasugrel are used. Glycoprotein 2B3A receptor antagonists like tibrofan, epitephabide or abixizumab are useful in high-risk patients with acute coronary syndromes. Then anticoagulants, including low molecular weight heparin and unfractionated heparin are used. Nitrates like nitroglycerin sublingual is usually effective. IV is also administered if pain persists or reoccurs. Beta blockers like atenolol or metoprolol are routinely administered in unstable angina unless contraindicated. Calcium channel blockers like amlodipine and nifedipine are also used if symptoms persist in patients on nitrates and beta blockers, or if beta blockers are contraindicated. Then statins, they have been shown to improve outcome in unstable angina. For management of acute MI, intravenous infusion of nitroglycerin is useful for persistent or recurrent ischemic pain and treatment of left ventricular failure. It should be avoided if there is hypotension and in patients who received sildenafil or tadalafil in the past 24 hours. In congestive cardiac failure or CCF, the role of nitrates in CCF is discussed earlier, like intravenous infusion of nitroglycerin is mainly used for acute heart failure. Monitoring of BP is necessary to avoid hypotension. Headache may limit the dose of nitrates. In case of hypertensive emergency, intravenous infusion of nitroglycerin is used because of rapid onset of action, but the disadvantage is development of tolerance. Then in case of biliary colics, sublingual nitroglycerin can be used to relieve biliary spasm and associated pain with it. In cases of cyanide poisoning, the oxygen carrying capacity of blood is not at all affected. Cyanide inhibits cytochrome C oxidase and prevents oxygen utilization by the cells. All tissues suffer from anoxia, that is histotoxic type of anoxia. Then treatment of cyanide poisoning. The main objective of treatment is to inactivate cyanide in the cells. In the absence of cyanide, binds to cytochrome C oxidase, causing the inhibition of oxidative phosphorylation. Amyl nitrate and sodium nitrite are used in treatment of cyanide poisoning. Nitrites rapidly convert hemoglobin to methemoglobin. Methemoglobin combines with cyanide to form non-toxic cyanomethemoglobin. Intravenous sodium thiosulfate converts cyanomethemoglobin to sodium thiocyanate, which is rapidly excreted in urine. Then let's talk about other class of drugs, that is beta adrenergic blockers. The beneficial effects of beta blockers in exertional angina are mainly due to negative chronotropic and negative inotropic effects on the heart. They block the beta-1 receptors of the heart and it decreases the heart rate, force of myocardial contraction, and it also decreases cardiac workload, and finally it decreases the myocardial oxygen consumption. Beta blockers have slow onset of action and are useful in angina prophylaxis only, not for the acute attacks of angina. Beta blockers improve exercise tolerance and reduce the frequency of anginal episodes. Use of beta blockers, those without intrinsic sympathomimetic activity, decreases mortality in patients with recent MI, hence it should be started early and continued indefinitely. Cardioselective beta blockers are preferred here. Beta blockers with intrinsic sympathomimetic activity like pindolol should be avoided as they may worsen angina. The adverse effects of beta adrenergic blockers include bradycardia, heart block, bronchospasm in patients with bronchial asthma, etc. Beta blockers can also increase left ventricular and diastolic volume, and it may lead to decreased cardiac output, and increased left ventricular and diastolic volume can worsen the cardiac failure. The disadvantage of beta blockers can be counteracted by combining them with nitrates. Beta blockers can exacerbate cardiac failure, peripheral vascular resistance, and may precipitate bronchospasm in patients with bronchial asthma. Beta blockers should not be withdrawn abruptly because this may precipitate dangerous arrhythmia or myocardial infarction. Beta blockers are contraindicated in variant angina, which occurs mainly due to coronary vasospasm. Coronary artery has both alpha-1 and beta-2 adrenergic receptors. Blockage of beta-2 receptor results in unopposed alpha-1 mediated vasoconstriction and aggravation of variant angina. So that's all, and the further topic will be continued by roll number 25. Thanks.